So good morning, everyone from New Zealand, and thank you very much for the opportunity to present briefly on gastric mapping. And in particular, today I'm going to focus on a new classification scheme that's emerging for these disorders. So as you all know, the definition and diagnosis of gastroduodenal symptoms continues to be a major point of controversy in the field, with a lot of discussion still really focusing on how to name these disorders, whether they're DGBIs, whether they're neuromuscular, whether they're overlapping, or represent a disease spectrum. Our focus has been, like others, to try and look beyond simple symptom labels and gastric emptying testing to get a layer deeper into the actual mechanisms that are driving symptoms in any individual patient. And these can vary between motor causes like accommodation or gastric dysrhythmia, hypermotility, caloric dysfunction, to more sensory causes such as our learned behaviors and psychological comorbidities, gut-brain axis dysregulation and sensitization, so on. And then some of these symptoms come, of course, downstream from the small bowel, duodenum in particular. In order to advance this, as many of you already know, we've developed out of the University of Auckland a new test called gastric allometry, which is a combination of high-resolution gastric electrophysiology, a non-invasive approach, together with symptom profiling during a test. And one of the exciting recent things that has happened is this test has now got TGA clearance just in the last few months. So I'm excited to say that it's now commercially and clinically available in Australia. So what this test does, for those who haven't been familiar yet, is that it picks up non-invasively the underlying electrical activity that drives contractions. And these, of course, come from the interstitial Salif-Kahal network in the stomach, although it very much also picks up the contractions that happen as they also cause a major electrical flux that we can pick up from the body surface. So the test is pretty simple for those who haven't seen it. It involves putting this patch on the gut and it's on the abdomen. And it's a very large array of sensors because these signals are so weak. They're about 100 times weaker than the heart. So in order to pick them up, we need this very large patch of electrodes. And they couple to this reader device here. So what does the test give? One of the main outputs is this physiological readout called a spectrogram. And as you know, the stomach makes slow waves at about every 20 seconds. So the frequency of these should sit very close to 3 cycles per minute. We've published a reference range of the normal outputs of the test, and this includes that frequency, which sits in a really tight frequency band between 2.65 and 3.35. And we also pick up the rhythm of the stomach. That's how organized the stomach's electrical activity is, as well as its amplitude, which should increase after the patient has a meal. This is a look at the symptom profiling app that patients use, and patients really like it. They feel validated being able to input a really clear symptom profile related to a meal. And it's very simple to use. The typical test takes 4 hours, and we give a standardized meal of about 450 kilocalories. We've now also introduced routine mental health profiling into the test because about 40% of our patients do have a significant mental health comorbidity, often anxiety, depression, or high stress levels. And so this is now routinely included, although it's optional for patients to complete. And it's just a 10-item questionnaire that's been validated in over 300 patients. So we put these together to give a multimodal profile of the patient, the physiology, the symptom profile after the meal, the correlation of the symptom profile to the physiology and the mental health to give the gastric allometry test. And we've now completed about 4,500 of these tests, many on patients. And that's allowed us to get a very large bank of data that's giving us a whole lot of new insights into pathophysiology. And we've been able to put patients now into a clear number of buckets that we call phenotypes. And we've wrapped these together as a new classification scheme called the Auckland classification that we hope is going to come out in the next few months. So I'm going to give you a quick preview of that now in the rest of the talk. So we've been able to pin down 5 specific categories that we see in the majority of patients who have this test, meaning that the patients are falling into specific groups that are either motor predominant or sensory predominant. And I'm going to run through the main motor groups first, the first of which is gastric dysrhythmia. So this is when the electrical signals that we record on the body surface are really disorganized. And we think this is largely, not entirely, but largely due to the loss of those interstitial cells of Cajal that drive the electrical activity. This is a recent meta-analysis that was performed in American Journal of Gastro, showing that in both gastroparesis and functional dyspepsia and chronic nausea and vomiting, there is significant loss on average of ICC, although it's probably a little worse in gastroparesis. So this is a spectrum. And of course, this is not all patients. It may be a quarter to a third of them that show these significant losses, but it's a significant amount. So what do we see on the test? Well, normally these waves, as shown, should be highly regular, spreading down the stomach in an organized fashion. And when these cells are lost, the electrical activity can be highly disorganized. And the body surface, that changes from a really regular rhythm here on the top to a very scattered one on the bottom, which we measure through a biomarker called the rhythm index. So this is the first major group in the classification scheme. The second one is a weak meal response. So in these patients, the rhythm is normal, but when they eat a meal, the activity doesn't increase as it should normally. So after you have a meal, the gastric activity should increase in amplitude. And what you're seeing here in this test, this is the frequency on the side here, and this is the amplitude curve at the bottom. And this is the meal in the blue line here. There's 30 minutes fasted and then 4 hours after the meal. So what you're seeing here is that after the meal, the amplitude should increase, but instead of increasing in this patient, it's decreasing. And that happens for about 2 hours. So this is an abnormal meal response, a weak meal response. And you can see that during that 2 hours on our symptom graph at the bottom here, that's when they're getting the majority of their symptoms. So a lot of postprandial distress in this patient associated with a weak meal response. This is what the symptom graph output of the test looks like on the right. And you can see that they're getting a lot of nausea, bloating, heartburn, stomach burn, and excessive fullness after they eat the meal. And these symptoms are correlating strongly with this period where the electrical activity and contractions are really weak. So this weak meal response group is the second group that we've been able to pin down in this emerging classification scheme. This paper came out recently showing a response to prokinetic therapy varied. And if the patients had this weak meal response, they were more likely to respond to prokinetics, albeit a relatively small sample size. Whereas if patients had the dysrhythmic phenotype, when the waves are very disorganized, their symptoms actually got a little worse on prokinetic therapy in this patient group. So some interesting treatment implications emerging there, currently being validated in a larger prospective study. So the third group out of the 5 is called high frequency, and this is when the rhythm is normal and the meal response is normal, but they have a very high frequency trace. And here's an example on this graph here, and you can see here that the frequency should be around 3, and in this case, it's up closer to 4. And that might not sound like much for the stomach, though that's a very significant difference. So with these high frequency patients, they often have severe continuous symptoms, and we're seeing this group particularly in long-standing diabetic patients. And we think it's emerging that it may be linked to vagal neuropathy, that when that happens, the frequency goes up. This is a study that's just come out showing response rates to G-POEM, and I don't have time to go into it in depth, but what it did really show that was interesting was patients who had a high frequency, that's this group here, were all above this line, which is the G-POEM response line, meaning none of them responded to G-POEM in this study. It's about 30 to 32 patients, I think. Whereas patients with dysrhythmia so far, they've all responded to G-POEM therapy. So it seems like this high frequency group, picking a group who probably have vagal neuropathy and turning out to be quite poor responders to therapies. So watch this space in terms of the phenotypes guiding therapy. So there's 2 other categories that are emerging from the classification scheme, and I realize this is quite fast, so we'll make this talk available online as well. The first one is a sensory motor group, and in this group, they have normal gastric physiology, but their symptoms correlate closely to the amplitude curve of the stomach. So when the stomach's contracting and working hard, they're getting the maximal symptoms, and when the stomach's finished, the symptoms are going away. And because they've got normal activity, but symptoms associated with that, we tend to think of these patients as having sensory disorders and more in the hypersensitivity camp. The last group is the continuous group, and these patients have normal physiology, but continuous symptoms. So their physiology is normal, they have a nice meal response, normal frequency and rhythm, but their symptoms just tend to just be almost continuous, very little in the way of meal response, and continue whether the stomach's working or not. And we see very high rates of gut-brain axis comorbidities, anxiety and depression in these patients in particular. So that's the new classification scheme, and thank you for the opportunity to talk. And I'll pass over to Phil for any questions. But as I say, this was quite a quick talk, so we'll also make it available online if anyone's interested, or please reach out to me in Auckland if you want to discuss more. Thank you.